Right, so we're discussing about the factors affecting the drug protein binding. So first the factor relating to the drug, like your physicochemical characteristic of the drug, then concentration of the drug in the body, then affinity of a drug for a particular component. Second is factor related to the protein and other binding components, like your physicochemical characteristic of the protein or the binding agent, then your concentration of the protein in the binding component, the number of binding sites on the binding site, like on the protein, drug interaction and patient related factors. Then first is your drug related factors, the physicochemical characteristic of the drug, like protein. As mentioned earlier, the protein binding is directly related to the lipophilicity of the drug. So it is directly related to the lipophilicity of the drug. If higher the lipophilicity, higher will be the extent of the binding. Example is the slow absorption of cloxacillin in comparison to the ampicillin after, sorry, this is a comparison here. Ampicillin after IM injection is attributed to its higher lipophilicity. It binding 95%, later you're binding 20% to the protein. Then high lipophilic thiopental tend to localize in the adipose tissue, and the acidic drug like your penicillin, sulfonamide bind more to the HSA, hemoserum albumin. Then cationic or basic drug like your imipramine, alpranolol binds to the AAG or alpha aminoglobulins. Then concentration of the drug in the body. The extent of the drug protein binding can change with both change in the drug and protein concentration. The concentration of drug that binding HSA does not have much of an influence, as the therapeutic concentration of any drug is insufficient to saturate it. Example is therapeutic concentration of the lidocaine can saturate the AAG, which it binding as a concentration of AAG much lesser in comparison to the HSA in the blood. So then your drug protein, your tissue affinity. Lidocaine have a greater affinity for the AAG than the human serum albumin. Digoxin have greater affinity for the protein of the cardiac muscle than the skeletal muscle of the plasma. Then coming to the protein or the tissue related factors, right? Then physicochemical properties of the protein or binding components. So lipoprotein and the adipose tissue used to bind the lipophilic drug by dissolving them to the lipid core. The physiological pH determines the presence of anionic or cationic group on the albumin molecule to bind a variety of the drugs. Then concentration of the protein or binding compounds or components. Mostly all drugs bind to the albumin because it is present in higher concentration than the other proteins. The number of binding sites on the protein. Albumin, your human serum albumin has a large number of binding sites as compared to the other protein, and it is a high capacity binding component. Like several drugs are capable of binding at more than one binding site. Like we have seen that it has, your HSC has 4 binding sites: site 1, site 2, site 3 and site 4. Site 1, that is known as the warfarin binding site. Site 2, that is known as the diazepam binding site. Site 3, it is known as the digitoxin binding site. And site 4, it is the tamoxifen binding site. Right? So more than one will like your fluoxacillin, florbuprofen, ketoprofen, tamoxifen, and diachromol binds to the both primary and secondary site of the albumin. Indomethacin is bind to the 3 different sites. Right? So AAG is with a limited binding capacity of it, low concentration and molecule size. The AAG has only one binding site for the lidocaine. In presence of the humans, HAS 2 binding site have been reported due to the direct interaction between them. So drug interaction or competition between drug for the binding site, or that is also known as the displacement interaction. Right? So when 2 or more drugs can bind to the same site, so competition between them for interaction with the binding the site results in one of the drug is bound to such a site, right? Then administration of the other drug B having the high affinity for the such binding site result in the displacement of the drug A from its binding site. This type of interaction we know as the displacement interaction, right? When the drug, your displacement is that drug, the drug A here is called the displaced drug and the drug B is as a displacer, right? Like example is your phenylbutazone displaces warfarin and sulfonamides from its binding site. So this is one example of displacement drug. So competition between drugs and normal body constituents. The free fatty acids are interact with a number of drugs that bind primarily to the human serum albumin. When the free fatty acid level is increased in the several conditions like your fasting, pathological, diabetics, then myocardial infarction, alcohol, abstinence, the fatty acid which also bind to the albumin influence the binding of the several drugs. Like binding is increased with the diazepam and propanol, and it is in case of the warfarin it is increased, right? So drugs like sodium salicylate, sodium benzonate, sulfonamide displaces bilirubin from its albumin binding site. That results in the neonate. It crosses the blood-brain barrier and precipitate toxicity, that is characterized, so that is known as. Then next coming to your patient related factors, then neonates, albumin content is very low. It is low in the newborn as a result of increased concentration of unbound drug that primarily bind to the albumin. Examples are like phenytoin and diazepam. Then in the young infant, an interesting example of difference in protein binding in infant is that of digoxin. Infant suffering from the congestive heart failure are given a digitalizing dose 4 to 6 times more than the adult dose on the body weight basis. This is contrary to one that infants should be given low dose considering their poorly developed drug eliminating system. The reason attributed to this is greater binding of the drug in the infants. Other reason may be the abnormally large renal clearance of digoxin in the infants. So in the elderly patients, your albumin content is lowered, result in the increased concentration of unbound drug that primarily binds to the albumin. In the old age, AAG level is increased, that decrease the concentration of free drug that bind to the amino acid, your alpha aminoglobulins. Then coming to your disease state, so as you know that your several pathological conditions are associated with the alteration in the protein contents. Since albumin is the major drug binding proteins, then your hypoalbuminuria can severely impair the protein drug binding. Hypoalbuminuria is caused by the several conditions like your aging, congestive cardiac failure, trauma, burns, inflammatory states, renal and hepatic disorders, right? The pregnancy or sugar surgery, cancer, etc. Right? So in this you can see the disease. In the renal failure, that is known as the uremia. Influence of the plasma protein, albumin content is less. So influence on the plasma drug binding, it decreases the binding of the acid drug. Neutral or basic drugs are unaffected. Then your hepatic failure, right? Like your decrease albumin synthesis is decreased. So decreased binding of the acid drug. So influence is that decreased binding of the acid drugs. Binding of the basic drugs is normal or reduced depending on the age level. Inflammatory state like your trauma, burns and infection, AAG level increases, so that increases the binding of the basic drugs, neutral and acid drugs unaffected. Right, significant of protein binding of the drug, like absorption, the binding of absorbed drug to the plasma proteins decreases the free drug concentration and disturbs the equilibrium. The sink conditions and their concentration gradient are established, which now act as the driving force for the further absorption. The systemic solubility of the drug, like your water insoluble drugs, neutral endogenous macromolecules like heparin, steroids, and oil soluble. This is circulated. Oil soluble vitamins are circulated and distributed to the tissue by binding, especially to the lipoproteins, which act as a vehicle for such hydrophobic components. Then distribution or plasma protein binding thus favors the uniform distribution of drug throughout the body by its buffer function. A protein bound drug in particular does not cross the blood brain barrier and placental barrier and the glomerulus. Then tissue binding, apparent volume of distribution and drug storage. A drug that binds to the blood components remains confined to the blood, have the small volume of distribution. Then drug that shows the extravascular tissue binding have the large volume of distribution. The relationship between tissue drug binding and the apparent volume of distribution, that is your Vd is equal to the amount of the drug in the body, that is equal to the C, divided by the plasma drug concentration, that is equal to the C. Then the amount of the drug in the body, X is equal to Vd into C, the volume distribution into concentration, plasma drug concentration. Similarly, among the drug in the plasma, your volume in your plasma concentration into S, right? That is the amount of the drug in the extravascular tissue, right? That is Pt into Ct. So total amount of the drug in the body, the volume of distribution of Vd into C is equal to Vp. That is, your Vp is the volume of the plasma, your Vt is the volume of the extravascular tissues, Ct is the tissue drug concentration. So Vd is equal to Vp plus Vt Ct oblique C. So dividing both sides by C in the above equation, the fraction of unbound drug in the plasma, Fu, that is known as the that is concentration of the unbound drug in the plasma divided by the total plasma drug concentration, right? That is Cu, and this is unbound drug in the plasma divided by the total your plasma drug concentration. The fraction unbound drug in the tissue, that is unbound drug in the tissue, it can be written as the concentration of drug unbound drug in the tissues divided by the total concentration in the tissues. Assuming that equilibrium unbound to the your free drug concentration in plasma and tissue is equal, so Ct by C becomes your equal to the Fu by Fut, right? Means Cu is equal to Cut, then Vd will become volume of the in the plasma plus into Vt tissue in the tissue, right? So this is your unbound drug and in the plasma and unbound drug in the tissue. So substituting the above value to equation 1, so this is the concentration of the plasma, larger its Vd. So coming to the your displacement, interaction and toxicity. As I stated earlier, displacement interactions are significant in case of the drugs which are more than 90%, 95% bound. Thus is explained from the example, right, given, like your a displacement of just 1% of 99% your drug bound drug result in you're doubling the free drug concentration. That means a 100% rise. For a drug that is bound to a lesser extent, example is 90% displacement of 1%, result only in the 10% rise in your free drug concentration, which may be insignificant clinically, right? So there are, this is the examples. Then example is your like okay, then we'll discuss in the next class. Okay, so discussing that, your kernicterus is in the infant is an example of a disorder caused by the displacement of bilirubin from the albumin binding site by the NSAIDs, non-steroidal anti-inflammatory drugs. Another example discussed earlier was the interaction between warfarin and phenylbutazone, right? Yet another example, displacement of that of digoxin with the quinine. So these are the example. So digoxin represents a drug with a large volume of distribution that will show the extensive extravascular tissue binding. Since displacement interaction may precipitate toxicity of the displayed drug, a reduction in its dose may be called for. So this may become necessary for a drug having a small volume of distribution such as warfarin, since the displacement can result in a large increase in the free drug concentration in plasma. With a drug of large volume of distribution such as digoxin, even a substantial increase in the degree of displacement of drug in the plasma may not affect a large increase in free drug concentration, and and dose adjustment may not be required. So this is for two reasons. One, only a small fraction of such a drug is present in plasma, whereas most of it is localized in the extravascular tissue, and secondly, following the displacement, the free drug, because of its large volume of distribution, redistribute in a larger pool of extravascular tissue. The extent to which the free drug plasma drug concentration of the drugs with a different volume of distribution value will change, right? So this is your displacement, interaction, and toxicity. So then you are coming to your kinetics of a protein drug binding. Okay, so this we'll discuss in the next class.